If you are a student in one of the classes, there is a sign-in sheet at the back here. Greetings, everyone. Welcome. Welcome all our colleagues. There will be probably some people trickling in here, so that'll be fine. Um, uh, my name is Tony Breitbach. I'm Director of Interprofessional Education here at St. Louis University, and it is our pleasure to invite and welcome you to our inaugural Collaborative Community Engaged Care Lecture. I have been told that the title of that needs a change, but it's a working title at the time. So, and we are very excited about the program we have for this evening. Also, we are excited to have a few of our colleagues here from St. Louis University. I'd like to recognize Lisa Dorsey, our Associate Provost for Undergraduate Education, who helps us lead the IP office. Thank you, Lisa. And Leslie McClure, our Dean of Public Health. Thank you for joining us tonight. And then we have many other esteemed faculty. We also have some of our affiliate faculty and members of our core team here. Can you kind of put your hand up if you're one of our advisors, adjuncts, member of the core team? Like, oh, yeah, there we go. There we go. Thank you. Thank you. Thank you very much. You know, this, about 2 years ago, we put into place this kind of new faculty model, and it's been working out great. I think one of the best parts about it is that you put some good people in a room together and give them some ideas and challenges, and they take it from there, which I think we've really come up with a lot of great things. So I'm really appreciative of that. And I'm also appreciative we have an esteemed panel tonight. We have and our keynote speaker and our moderator here this evening. And we have probably about 20 some people on the webinar also. So welcome to all of them. And one of the things that we would like to do with this is we would like to really have you be comfortable engaging with the. So if you have questions, those kind of things, we'll come around and give you a microphone and you can ask questions. So I'm going to get started. First I'm going to introduce Dr. Katie Heiden-Rootes. She is a professor in medical family therapy and also the vice president of belonging. Oh, diversity, and yeah, she can continue to introduce herself, but it's an office that's transitioning right now. So but either way, it's a high impact position. So I'm going to let her talk a little bit about herself and then introduce our keynote speaker. So thank you, Katie.
Thanks, Tony. I just got a promotion. Did everybody hear that? Because Thank you. If you could tell them, that would be great, whoever they are. Um, Thank you all for being here. I'm really excited to get to introduce our keynote for tonight. Some of my earliest clinical work when I was a baby family therapist very long ago, for the students in the room, was in foster care. And in foster care, domestic violence and substance abuse are the number one and two causes, right, for why kids end up. And I knew nothing about any of this. I was brand new to the field and learned very quickly the impact on little bodies and little people. And so I have known since then how critical this work is. And so I'm delighted you came all the way from Western Australia to visit St. Louis in the cold tundra that we now sit in. It's usually not this cold. But really excited, Elsie, to hear about what you all are doing there, what we can learn from you, and also what it looks like to really think cross-culturally and intersectionally, and those things are still vital to kind of services we provided. So Elsie Bay is here and is from Ruah Community Services and is going to kick us off with the keynote.
It's on? Are we good to go? Perfect. I'm going to set a timer because it's so interesting and I could talk about this forever, so I won't do that. Thank you so much for the introduction and thank you for having me. It's been such an amazing couple of days being here, so yeah, the learning is very much mutual. I'd like to start by acknowledging the traditional land. In Perth, every time we do a presentation, we start with acknowledging the traditional landowners. For us, that means recognising the history and continuing the ongoing work that we need to do in recognising reconciliation and the commitment to social justice and the inequities that exist. So I think that's really important and reminded again of that today with Dr. Travis Threats around the work we need to do ongoing and how that looks different here. So it's an important kind of grounding in the work that we do. All my slides. These ones? There you go. So I think to start by why we do this work. Really at the heart of this for me is that every person has dignity, regardless of what the situations are or where someone falls. We do this work because societies need to be inclusive. We want to make sure that people can thrive and have lives that are better. And I think, we do this work because of the Sustainable Health Goals, but really at the core of this is dignity and inclusion for all people. At Ruah, we talk about walking beside you and walking with you. And I think this is really important to share that we're doing and why it's so important. We know in family and domestic violence that 11 of the SDG goals are impacted. So I think that's, really good. Family violence being an issue cuts across every area. A health issue, social issue, family issue. I think it's something that affects every element. So talking about the Australian healthcare system and some similarities and differences. I think drawing on the last couple of days, we know that in Australia, it's universal healthcare. But I think what we really know is that how that looks in prevention. So when it's universal, prevention is everybody's responsibility. Where when it's private, it's more up to the individual. One of the things I was talking to the students about yesterday was what it's like in Australia. If I take my kids to ED, I'm worried about the wait time, but it's free. And I think that's one of the key differences. In Australia, the health budget is 10% of our GDP. So we're really lucky in so many ways. We have things like Centrelink and Medicare, which means that everyone has access to the basic things they need. And it's consistent across Australia. So what you'd get in Melbourne or Sydney, on paper is the same as what you get in Perth. And that universal coverage means that we all have free access to what we need at any point. So broadly, we have publicly funded government healthcare. I think in terms of government control, what that looks like is that our decisions at a government level are informed by public health choices and economic choices. So again, I was talking to a student today around bike helmets. They're obviously mandatory in Australia. And the reason they're mandatory is because the cost of taking someone to ED and having a trauma can be up to 100,000. So decisions like that are mandated and they're government-wide. In comparing Australia to the US context, I think one of the most interesting things about the United States and the strengths is the specialty, the excellence, what you guys have in terms of like the very best of medical support. I think with that and the philanthropic model, you've got the ability to pivot and be creative quickly. You've got areas of huge excellence. And so I think that's a real strength. And we were talking today around how do we take from each other's systems to make sure we can all have the best. One model is perfect. We've got lots of good things like universal coverage, a strong baseline. But I think what we don't have is the ability to pivot quickly when we find something that's absolutely amazing. So while you guys have, maybe it's more fragmented and state by state, you've got the best of the best where it's working really well. I think when I look at the two models, the standout thing for me, the two systems, the standout thing to me that's been really curious over the last few days is around the mental load that young people carry in the States. And I think one thing that's really curious to me is that in Australia, no one in their 20s or 30s knows about what insurance we have. Like it's not front of mind. It's not on our mind when we're looking at having a family. It's not on our mind when we're planning decisions around risk or anything. I think it's really taken for granted. And hearing so many young people over the last few days, I felt really sad about it, really, because it's something that for us, although there's a fragmented system and although there's unmet need, it's not on young people's minds. You know, maybe global warming is, and housing affordability, and you know, racism and things like that, but definitely not access to healthcare. And so hearing that from young people, I think is how it shows up, and I think, yeah, the mental load is something that we don't have in Australia. That's my standout. So while we have in Australia universal health coverage, it's not perfect. And I think, you know, the key issues that we face are around the inequities for our Indigenous people, fragmentation across different areas depending on where you are, specialist medicine costs. So again, we've got general universal coverage, but when there's things like a new chemotherapy or a new specialist drug, there's high costs for that. There's huge inequity across income, geography, culture, and race. And another one, which I'm sure isn't unique to Australia, is the pressures of workforce shortages and wait times. So while we have a great ED and while we have free paediatric care, if you're in the public system, it's obviously there's large wait times. And because our EDs are so good, it's easy to go there, and lots of people go there instead of to say, go to a GP. So structural racism in Australia is a huge problem. And really acknowledging the so much work we have to do to address this. We talk about truth telling, and it's every day. Aboriginal Australians is absolutely shocking. Until 1970, children were forcibly removed in the stolen generation. And the disproportionate impacts for this affects every element of this amazing culture's lives, from health to family, family and domestic violence. Disproportionately, our First Nations people have negative health outcomes. So we have such a responsibility ongoing to make sure we address this and really I think, listen and learn from their rich culture to be able to close the gap. Again, in having that we have and universal healthcare, it's really disappointing and a tragedy of where we're at and the way that we're dark in this. I think it's probably something about Australia that's not well known, but is something that we should all be really ashamed of. There's absolutely things to acknowledge in the past, but still a lot of work for us to all do in remedying it today and in the future. I think in addition to the uncomfortable truth of racism in Australia, and the one is WA. So I'm from Perth, which is the capital city of Western Australia. I think Western Australia is about the same size as Texas. Does that sound right? It's a big state. We're the richest state, but we have the poorest. So per capita, we're very wealthy, an economic boom in terms of mining. So in areas that huge income disparity, and we're isolated. So it's a unique context in WA. We've got huge wealth from mining. We're really far away from anywhere else. And we've some of the worst outcomes. So if you look at universal health, it doesn't really work when the doctor is 8 hours away. It doesn't really work if you call RFDS, which is our flying doctor, you're in a remote town. No specialists available in the bush, it's not really universal care. So while we have all these great things, the life expectancy and health outcomes when you're in regional and remote areas are far less. So if you think of WA where there's people around the edges, but the middle is empty and really remote. So there's huge inequities there. And for us, we look at how we can address that with digital enablement, bringing STEM, but it's a real challenge for us depending on where you are in the geography. So I think, yeah, to show some context, we've got teams, we have services where there's, 700 kilometers away to get help. There might be a roadhouse, there might be food and water, but we're so sparse that the geography is a real consideration. So in terms of Ruah and who we are and what we provide in WA. So Ruah provides services around the core areas of domestic violence, housing and homelessness, and mental health. We also provide services around legal representation. Now, what we know about these areas is that whichever door you come through, you're more likely than not have needs across all those areas. And when we think about people as people, what we know is that regardless of whether you come to us needing support with family services, education or mental health, humans, we all have such, we call it co-occurring needs in a system level. People are people. What we do, navigating that complex system behind the scenes so that when you come in, you can get what you need at the right place at the right time and have the right care. And I think that's what we build our model on. In this, we talk about being bold. We talk about a lot. Really difficult ones to solve. They're so complex. They're wicked problems, and I think no government or university can solve them alone. I think we all play such a collective part in being able to address these and tackle these issues. Like this, to connect and work together, make these problems something real, feel like they have a part to play in it. So in terms of family and domestic violence, one of the things that stands out is this statistic. 53% of people don't think FDV happens with their friends or in their suburb. Domestic violence, this is just the tip of the iceberg. When people come to us, we capture the records, but it's a tsunami of a problem. It is something that happens in every area. It doesn't discriminate across postcode or geography. And it's something that affects health, education, every single layer, and every area. So I think, yeah, this stands out to me because really important that no matter what role you're in, no matter what part or industry that you're in, you acknowledge that it's there. It's part of the landscape. And what can you do to either call out behavior, question something, or learn more and be part of the change. Just to clarify, 53% of people think this doesn't happen. No, it does. No, it happens everywhere. And I think this is people think that happens in their backyard. And it wouldn't happen to people who look like me or who go to that university. It does. It happens absolutely everywhere. In Australia, the facts are absolutely shocking. 1 woman every 5 days is murdered at the hands of their partner. And in a place where they should feel safe and be at home and have trust, what we are seeing is an absolute epidemic. Family and domestic violence is on the increase, with Western Australia having the worst rates in Australia. Outside of the Northern Territory, all other states, WA is leading. We know, in addition to the rates, the intersectionality. So our First Nations brothers and sisters are 33% more likely to be hospitalised due to FDV. We know the intersectionality, people who identify as LGBTQIA+. And we know that people with a disability are far more impacted by DV as well. So I think, seeing this, understanding the absolute scale of this wicked problem, again, it's just the tip of the iceberg, because these are the stats where we reported deaths. Coercive control goes well below that, the patterns of fear and violence and the impact they have. I think in addition to the human burden of family and domestic violence, the economic cost is huge and the impact to every system level. So $26 billion is the cost of gender-based violence in Australia. And we know that only 2% of funding is in prevention. So one of the things we talk about a lot is the investment needed in looking at this problem far before it happens, in terms of education around gender-based violence, in terms of primary prevention for how we work with our young people and respectful conversations. Similar to the cost of diabetes care and road accidents. It's a cost that affects every layer across, social health, justice, and the physical impacts are massive. So in terms of what we're doing about it, what we know that works is right time, right place, right care. And this is so important to us because what we've heard from the women and children who use our services is that going to one place is what works. When you have lived your life in crisis and you're in fight and flight mode, the last thing you want to do is navigate the system, knowing which place has which eligibility, who's going to be able to look after me in this way. It's the last thing you can think about. You've got your children with you and you're looking at your own safety. So we talk about a no wrong door approach, making sure that you can go to one place and get your needs met. Based on the important voices of the women and children who we've worked with at Ruah for over 60 years, in terms of building in research and working with our partners, we've done what we need to do to make sure that there's a collaborative approach to family and domestic violence. Angela Wright Bennett Centre is a service that's 1 year in, and this is an integrated service that has all these things in one. So this is in Perth, our integrated service. This is the first of its kind, being able to have services on site, accommodation on site for people to work on healing and recovery for women and children. And the comprehensive support allows them to come in and have all their needs met in one place for free and for as long as they need. I said to one of the workers before I left, what's one thing you want me to tell people in the States about Carlup? Like, what's so good about Carlup? And they said, well, how cool is it that you can go to one place and you can see the nurse, have your STIs checked, see the lawyer, you can go to the GP and get your script, do your financial counselling, get some of that debt down, see the housing worker, all in one day for free, and send you home with cash. And I thought, yeah, that is a great way to describe it, because providing emergency relief for people to be able to fill up their fridge, get their kids' school shoes, are the really practical things that make a huge difference and make sure that people can have what they need to thrive. Now, model, integrated services is designed, which we've worked with elders in our Aboriginal community, and we've worked with victim survivors and experts to build at the beginning. So what that means is that we can do more of what works. We can pivot in real time. And in terms of funding, while we have state funding from the government in Australia universally, we've been able to have generous philanthropic donations. What that means is being able to do some of the good things you guys do in do more of the extra things which give flexibility. The government funding is rigid in outcomes, systematic, the same across the board. Philanthropic money for us in this model has allowed us to be able to change things in real time. So if everyone is using the housing worker and the financial counsellor is full, we'll just hire 2 of those instead of hiring the model. So right in real time, more of what works. The unique thing, support is there for as long as you need it. So we know that recovery and healing isn't something. The impacts of family and domestic violence is lifelong in every element of someone's life. And so what we've heard from people is that being able to act as long as they need with no judgment, if they return to the perpetrator and then still come back, you know, a woman leaves their partner 7 times on average, and we need for them all those times. So I think, you know, so often we ask the question of why don't you leave? But the question we should be asking is what happens when you leave? And there's no options. So in building Carlup, we really have thought about and have designed experience family and domestic violence to recognise the ongoing impacts for children and for women and for the whole community. You can see the wrapping around the model there is a trauma-informed approach, safety, cultural awareness, and trust and rapport. It is one of the things has been the hardest year of operations. It's been really hard. Integration and delivering integration, I think, is the hardest thing I've ever done in my career to really do it. All the multi-D team working, our multi-D team is, I'll show you soon, to working in the same direction, but the outcomes have been incredible. And I think that's key, and we hold ourselves to that throughout the model, to listening to the voices, and if we need to change something, we change the model, not being bound to it because we began. So in terms of embedding health services, we've really seen this as the missing piece in family and domestic violence. We know that for people to be able to thrive and recover and heal long term, they need to meet every one of those elements across a pyramid. And we know it blocks every single one of them. It blocks your ability to be safe. In terms of poverty, it eliminates your ability to find food, the sleep impact, the trauma, the hypersensitivity of living in that state of fear. Across all of those areas, and primary health being key in addressing those acute medical needs. Because one, you can't heal and recover and thrive and flourish as a community or as an individual if you've got pain if you've got, chronic diseases that aren't managed. There's such basic things, but it's really been the missing piece for us in taking FDV as a social and looking at it equally as a health issue. So this year outcomes at Carlup, I want to picture what our service looks like. The design of that bedroom there and our creche are examples that this service is built really intentionally, with people who will use it and how beautiful it is. And we strongly believe that buildings and spaces that are beautiful, and the women have told us how the impact that has on their lives and how they feel, in a place that says you're worth it. So many of our refuges are not like this. These are exceptionally beautiful. And we're doing research with the University of Cambridge around the impact of that design on people's healing. Because what we know about that is that the way they feel, and the women have told us that they feel worthy for the first time in years. And it's probably something that I didn't recognise enough until we did this work, but it really makes a huge difference. We're in, we've just been open a year. Scene that's been really surprising, something I didn't expect, was the utilisation of health services. So we've seen that 91% of people using the service used health. The other thing is the intersectionality. So 25% of our clients use 6 or more of the offering. And so we have specialists embedded across all these areas of Carlup. They're all available. That's been hard in designing the model to make sure they're all available. At an operations level, running a service, building in flex is really hard, because if I want to make sure there's time for you to be seen today by any of those workers, you need to build in free time. But then you build in free time and you have bottlenecks. So that was really hard. I guess what we've done over the first year that's worked really well has been hacking the system and kind of breaking the model. We've looked at things in terms of what can we just try that's different that might work. So, for example, when we began, you needed to see one first and then go to the nurse. But the nurse was free and the other one had a massive wait list. So we've just flipped it in real time. And we've had the ability to do that because of the philanthropic funding and the flexibility in this model. I think being brave as well, and let's try it. Let's see what happens. And what's happened is that 91% of people did need health. And so I think that shows massively that I think on average, each person saw the health services 10 times. And that's across, that is across the areas of, the highest things is chronic disease management, immunisations, child development's a massive one. So when you're running and you're in crisis, the fact that your kid's not been listening in school, or developmental delays, maybe you didn't get their ears checked, that's not on your mind. When you're in crisis, you're just looking after your safety, and you're living in a state of hypervigilance. So being able to have health wrap around has meant that women can really work on healing and recovery and address those things that they didn't before. So in terms of outcomes 1 year in, I will talk to the different models that we use. So this is, built in with University of Western Australia. From the beginning, we've designed the model so we can really have measured benchmark tools that show the improvements and check, is it working, and have independence to tell us maybe it's not. We've got some impressive outcomes and I'll speak to them, but one of the things as I left that really stuck with me from the women and children who use it is them talking about what it means to them. I think we can quantify these outcomes, but for the children, who for the first time are going to school, for the kids who are sleeping through the night now, they're the outcomes that I think don't show up on something like this, are so meaningful. And I think, that's another a piece of flexibility that we've got, is being able to say, well, how do we measure that outcome and make sure we are capturing that, because that's really amazing. I think for me, the thing that's really surprised me is that when I when I go to work in the morning, our officers are also on site. All the kids are now in uniforms and they're going on the bus to school. And that sounds so normal, but that wasn't the way when we started. So I think the work it takes is so unseen to get a kid to school. You know, the anxiety, the fear, getting a uniform and the logistics, like so many of those elements, and now seeing these kids look like any other kid on the school bus, going off with their laptop, like it's things like that that you're like, wow, this is working. And that's something that I think is really amazing. But in terms of the actual tools, so we've got 3 tools that we use, and we've seen, you know, across 60 to 70% improvement, which is just amazing. The star is one that showed it's a self-rating star. In terms of life, it might be how you're going with friendships, alcohol and drugs, with housing. You kind of rate it in terms of all the different domains. And so this is a self-rated star. What we know with this star is that the more insight you have or the more time you work on the work you need to do, often you'll realize that your score is less than it was to begin with. So ongoing with this is the longitudinal outcomes have the biggest impact, and acknowledging that we're 1 year in. So these are early indicators, not, you know, official research by any means. The is here we're using, which is a benchmarked FDV tool. Again, the increases that we've seen is really around self-worth and self-acceptance. And they're things which have a huge impact, although they might not sound like health outcomes. They're really huge because women's lives experiencing FDV affects every single element. And until those things are managed and addressed, nothing else can really happen. And the general health questionnaire. So again, we've seen health across every single area, mental health and emotional health being the biggest increases in being able to really improve in those areas. And that's huge gains. So yeah, we're really like, our outcomes are so important to us to be able to evaluate and test and benchmark across other populations who have similar experiences. I think the 40% who haven't improved is equally important to understand. Not because it's a failure of the system, but to understand where we need to go next, to understand what that's telling us, to understand in the system, where are the unmet needs. I think often we look at services and saying, this has been our increases in it's a success, which it definitely is, but more than that at a system level, what aren't we understanding? Like we should be looking, I think, at the 40% to grow and learn and do more. So children and children's outcomes in the service. Children have been a really important part of the service to understand what it means for them, different and separate to the adults. Children have their own experiences of FDV, clients in their own right. And so in addressing the children's needs in the accommodation and in our services, it's been a focus on how we do this and how we can continue to do this better. Here, I think, you know, the key take-homes that we've been able to achieve and that's worked really well is flipping the model, being able to flex it and break it in ways that we didn't anticipate. Going live with a new model, with new data, new systems, new staff, new clients, new everything on day one was really hard. Working in a new way, and I think in a multi-disciplinary team where the same t-shirt and look at the client in front of you with the same lens has been really difficult because people come with different worldviews of what good looks like and what excellence in care looks like. So we've done a lot in multi-D teams, I guess, but really hacking that. It's been really hard. Made huge gains in it, but it's continued work around how we do that. In terms of next year, our priorities and our focus are to embed more specialists, to do what we've seen works and do more of it. So have more clean sites. We've got someone coming on to do educational programs for kids. We've got more healing and recovery workshops. In terms of our wait list, we've got huge demand, more than we can ever supply at the moment. So the ongoing work to make sure that we can, how can we better address demand in the regions, in WA, and to make sure that people have that ongoing support they need for as long as they need it, while addressing and providing for people who are in need today. And I think, again, further embedding our measurement tools to make sure we're doing more of what works, and that we're able to really understand the needs for the service. So at Ruah, we talk about what's your piece. And that means that at Ruah, we know our piece is providing services. We know where we... I think, to me, what's important about this conversation is that everyone knows their piece. Like, what's your piece in FDV? It may be as a fight of girls and having conversations around what gender-based violence looks like, or consent. It might be calling bad behavior at a barbecue, or questioning something of, like, on a group text, like, is that funny? It's a subtle thing around how we can ship ourselves and as a collective. Because I think, as I've said, this problem is far too big for any of us to solve alone. But I think, these are issues which can be solved, and together we do have that collective to start addressing it and changing the direction. I think sometimes this space feels like you're paddling upstream, and it's, a tsunami of problems coming at us constantly, and you can never meet demand. But what we do know is that the impact of one person believing in a woman and believing them and hearing their story, or telling them where they can go for help, or at least they don't want to leave the perpetrator, and being beside them, they're the things that for that person is massive. So I think, the reminder that we all play a part in this, and, together we can, drive this and do. And while we're in a system that's hard and fragmented and we don't have enough funding ever, what are the hacks we can do to make sure we can do something? Because I think there is so much potential and so much positivity. So yeah, I think that's the message I'd love everyone to take, of, like, what's your piece, and continue that conversation. Thanks.
Thank you, Elsie. We're going to continue with the panel discussion. And so we'll get up here. It might take a second, but thank you. Feel very fancy at this table, Tony. Yeah, awesome. All right. There's one. Okay. We're going to start briefly with introductions of the panel, and then we're going to jump right into discussion and reflections. I was joking with the panelists before that we're going to have a conversation, and you all get to just be flies on the wall and listen in. And I asked Tony where our wine was so we could really have this conversation, but there wasn't any. But there will be time also for those of you in the audience to ask questions. So you won't just be listeners in this activity. All right, so let's start with some introductions. Alesha, you want to kick us off?
Hi there, my name is Alesha Durfee. I'm a professor of women and gender studies here at St. Louis University. I, back in the day as a graduate student, worked as a domestic violence advocate on crime scenes for the Seattle Police Department, which completely shaped my research. So those of you who are students, I really urge you to get in the field. And I do work on domestic violence protection orders and mandatory arrest policies here in the US.
hear me? Because I'm more of an informal speaker. Is that okay? Can you all hear me? Oh, it needs to be captured. Got it. So I have to. Good evening. Thank you so much for having me. My name is Vithya Murugan. Excuse me. I'm an associate professor at the School of Social Work here at St. Louis University. I'm also the director of our undergrad Bachelor's of Science in Social Work. Sorry. Prior to my academic journey, doing my Ph.D. at Washington University in St. Louis, I completed my undergrad and master's at Rutgers in social work. And then I followed that up with working as a domestic violence counselor. And so that really shaped how I view this work, especially the tenets around advocacy and empowerment and really grounding the lived experiences of survivors. Currently, my research collaborations include with my esteemed colleague, Terri Weaver. We're currently speaking with Black survivors of domestic violence in St. Louis, and really thinking about what their experience has been accessing formal services and thinking about barriers. So I'm really excited to be here and to talk to you about the work that we're doing.
Hi, everyone. My name is Stephanie Null. I use she, her pronouns, and I'm the executive director of St. Louis Anti-Violence Project. I think prior to this role, I've only been in the role for a year and a half, but prior to this role, I have been in the nonprofit sector. And I did everything from program management at a youth program, workforce development, poverty elimination. And I could say the through line outside of poverty was that I was consistently referring people to domestic violence resources and anti-violence resources. So for me, this work is very important. I've been doing it for 20 years. I'm also a survivor, and I'm represent the LGBT community. And so going into this role, you'll hear some of my own personal experience, but you'll also hear some of the professional experience that I have learned over the years as well.
All right. Good evening, everyone. My name is Terri Weaver, and I am a professor in the Department of Psychology, Clinical Psychology here at St. Louis University. I've been at St. Louis University now for 27 years and also worked within the domestic violence community, both as a clinician and a researcher for that period of time. And one thing you need to know is that those of us who do work in this area, we work in family violence and we are like family members. Like, you build strong bonds with the folks who do this work, not only because we share such a passion for the work, but also because this work takes a toll and we need each other as we're doing this work in order to sustain ourselves and to give support to ourselves so that we can support others. Like others on the panel, I started as a domestic violence advocate right out of undergrad in Fairfax County, Virginia. And in doing that work, I really shared a lot of the questions and biases that we hear folks say, sort of the, why doesn't she just leave? Why does she go back? And one of the things, Elsie, that we kind of, another researcher and I have said as a different kind of question or rejoinder to why doesn't she just leave is, why doesn't he let her leave? And you know, some of what we'll be talking tonight are some of the barriers for making changes, not just in relationships that have violence, but just making changes in relationships in general. And that's kind of one message that I want to share. This isn't like domestic violence over here, and these are those women. We all have struggles and challenges in our relationships, and ending relationships is just hard. And I don't want us to forget that domestic violence occurs in the context of a relationship. So that is me, and we're excited to get the conversation started.
Thanks, everyone. So let's just start with some reflection back to Elsie about what she shared. I think you started some of that, Terri. Some reflection on what folks maybe are connecting to their own work, what they're thinking about. Your last question was great. What's your piece in ending domestic violence? So I'll let each of the panels kind of decide what they want to reflect on or what they were thinking about, and then we'll go from there. Anybody want to be first?
Why not? I think for me, when I was just looking at those pictures, the images that you showed and how beautiful they are. And as a social worker, one of our core values is the dignity and worth of people. And that really just resonated with me, walking into a space and feeling like you're worth it, right? That really immediately just, made me kind of emotional thinking about that type of reception for the women that we advocate and do this work for. I also think about the one-stop shop and that being like the dream, the ideal, instead of these fragmented resources where it's you go here, and by the time you get to where you finally need to be, it's just has taken so much time and it's often demoralizing. And so making that more of the rule than the exception. So those were some preliminary thoughts, but I really enjoyed reading more about the work that you all do.
I think something that also really stuck out for me, for anybody who doesn't know about STLAVP, we don't provide direct services. So the work that we do is bringing awareness around relational violence within and to the LGBTQIA plus community. And so we do that through education and technical assistance to nonprofit agencies. But when you were talking about the one-stop shop and the work that you all have been doing, it's so inspiring because in St. Louis, there is not an LGBTQIA plus shelter. There is not an LGBTQIA plus explicitly LGBT plus survivor services. And so thinking about like, what could this look like in this arena? And what kind of partnerships could we have to make this really flourish? And I think you brought up funding. Like funding is going to be hard. It's always going to be difficult. But how can we get, if one agency can't do it, how can we get several agencies who really care about this work? And so that really stuck out to me of like, what would it look like if we had a place that if you are a survivor, because survivorship occurs over all identities, you could be a cisgender male, you could be trans, you can be non-binary, you can be a cis woman, you can be bisexual, you can be straight. How amazing would it be to come in as your authentic self and that not be the problem, but that you're going through some of these issues and that you can move forward? That to me was just like, oh my gosh, it started spurring all of these things in my mind.
I think I want to expand upon that. And one thing that really struck me in your talk, and I really did enjoy everything about it, it's really inspiring to see how people do different models, is the no wrong door conception. And I think for me, I like to think about just a whole community as coming together to address domestic violence. That also goes to your last, like, what is my role? And so all those disciplines, whether it is, and this is kind of such a appropriate topic for interprofessional education, because all disciplines have something to contribute to this, whether it's a pharmacist, whether it's a dentist, a primary care, OBGYN, neighbor, bus driver, somebody working, at the Salvation Army, at the thrift store. Like, if you listen and if you see somebody who's hairdressers, if you hear something going on, how can people know how they could step up and what they could say? And it isn't always, it doesn't have to be something that's a big thing. Some of it is just showing humanity. It's a key thing in breaking the cycle of domestic violence is having a person who's experiencing it be seen and to break the silence. And once that silence is broken, and then help can, come in. There's one sort of thing that I want to say about the one-stop shop, because we did try to do that in St. Louis a bit, not really focused on different identities, which I think is really badly needed. But there's some reluctance in a former model for the one-stop shop because of some of the fears around child protective services being co-located. And so I think it's very important when we think about these models to engage in to have participants who are experiencing domestic violence to weigh in on really what would be helpful to them, and to have those voices heard and the participatory kind of development, because we might think something is a really good idea, but we have our, our blinders, we have things that we're not aware of. And so, there may be some important modifications that are needed.
There was just so much in your presentation that I was so very excited about. Some of the things that I really appreciated was just this basic emphasis on safety, that we're going to build to a certain point, but we have to have those basic needs met, right? Someone is in crisis. It is not the time to work on self-esteem. That's a great goal, right? But that you are going to layer on that. And so looking also at flexibility and being very like cultural awareness. And I think it comes to some of what you were saying, Terri, where we definitely don't have a model in the US that is no bad doors, right? We have one door. We have like either medical or criminal legal, right? We have very specific doors. And if you are not in those doors, my goodness, we will force you through those doors. And it comes from a long history of lawsuits and, the Battered Women's Movement and Violence Against Women Act. And there are very good reasons for that. But I think, 30, 40 years later, it's exciting to think about what would a different approach be where there was no bad door. And if if the lawyer had a backup, maybe you could see the nurse, right? And I think that pivoting and flexibility to meet those basic needs, and then this idea of lifetime support. I think we also, in the US, just historically, there's been a lot of boundaries, right? I'll support you, but you have to do X, Y, and Z. I need to see you making this progress, and it's the progress I think is good for you, not your goals, right? And what I see here is this flexibility that is very exciting. One of the things that it was almost an offhand comment, but that I wrote down is you were like, trying to build an interdisciplinary team where somebody doesn't want to leave. And I was like, people don't have to leave. They have to be safe, right? But we sometimes forget that in the US. We're in a rush for separation-based solutions, and it's refreshing to see an agency that is focusing on safety and security and healing solutions. And I know we all, the word thrive is really important, but that kid on the school bus, I work with students who are in crisis, and I tell them now, one day your life will be boring and normal. And that's all they want. They want to be, they don't want to be thriving. Honestly, they want to be bored. They want to be able to put it all down for just a minute, because we pile on and Paige Sweet has written about this, the politics of surviving, right? And so I love that you are meeting them where they're at. And then I applaud your work to create teams and the issues with interdisciplinary teams. I think we can everybody in this room can relate to what it's like to that first year of getting together a team. And so for you to have these remarkable results just in 1 year is really amazing.
Thank you so much. It's really amazing to be doing this hard work and to come here and feel such support and strength. I think in meeting, you guys, as we were having a sandwich just before, there's something really strong about like we're in this together, because it is hard work, right? Not only hard for us, but I mean the problems we're trying to solve so often feel like impossible, right? And the numbers are going up and everything's against us. I think one of the things that, the theme across that all of you have spoken to is about recovery. And we know that recovery doesn't happen in a silo. It happens in relationships. And the time it takes and the trust for women and children to come back on their terms and tell us what they need and what the good life looks like for them. That's the focus for us. Of like, what is that? What is the good life for you? If it's living in your home with the perpetrator, that's not our call. It's about looking at what support looks like for them and walking alongside them in their life so that they can thrive. One of the things that, in terms of the one-stop shop, I completely agree, by the way, around child protection. It's a challenge that speaking to trust, it's a massive thing for us. And building an integrated service, one of the key enablers has been a real focus on data and systems and having a shared platform where we can all speak the same language, have outputs that show us what researchers need. Very, very difficult. Very, very, very difficult. It's been so hard. And then child protection being a lens of that, of how we are mindful of what we are doing to make sure that we build trust for families and safety alongside that. I think just one other surprising thing that I forgot to mention was the importance of the creche. So the creche in the service probably wasn't something that I valued at the beginning, to be honest. It sounds terrible, but the creche is the one thing that is the enabler for all that integration. So the reason that on average, one person uses 4 services and 25% use 6 is because the kids are in the creche. They're safe, they love it, they want to go back. And you can imagine for a mum who's the kids' safety is like top priority and they're used to the fear of letting them out of their sight, that's been the enabler. And I think having that on site built around, they take little buzzers with them. So if the kid needs anything, they can come back, so built in around the physical design of the building. But I think it's one of those simple things that doesn't sound as impressive maybe as the legal services or as the dentist that we have on site for free. That's all really impressive stuff. But the creche has been the thing that has been the enabler for all of the interdisciplinary teams to work together. Because once the kids are safe and there's time for them to, no bookings or anything, they're just there, then of course the mum's going to use all of our services. And I think the housing worker is the other surprise. Housing, we have a huge housing crisis and affordable rents. There's 0 affordable rents in WA. On the New Start allowance. So having a housing worker planning for what safe tenancy looks like from the day you come in is a massive enabler. And we're going to add to that and have another housing worker so we can address our wait list, because the only way to do that is get people in stable housing.
Wonderful. Thank you, everyone. I have a question I want to follow up with, but you made me think of something and I have the microphone, so I'm gonna no, what I kept thinking of, you all have used the word, you used the word flexibility. Folks have reflected that, no wrong door. So in my field in family work, we talk a lot about attachment security and safety. And when I think of flexibility, I think of responsiveness to someone. And it sounds to me like your system is responsive to the individual, the kids. My bias is the kids because of my work, but I think it's really beautiful in terms of creating like a secure attachment system around the family. And it seems to me that's what you all have built or are continuing to build. And so that's really, really beautiful. So I have a question, and anyone can start us off here, but you have up here several researchers and somebody in community work. And one of the questions we had discussed was, how can organizations ensure lived experience voices? So women, children, folks who are part of the LGBTQ community. You all are doing research with Black women in St. Louis as another important demographic, remains central to programming in terms of how it matures, how it scales. And so anyone can take that question, but really thinking about how we center those voices of folks who have been through it and are survivors.
Am I on? Okay. So I think one of the key things is that we need to just ask our community. I think we get so hung up on all of the professionals in the room and all of the experience that we have and all the data we have collected. But I think when we really live into creating something that is of the community and helps the community, that means the community is a co-designer in that work. And so, at SEL AVP, every 5 years, we have gone to a downtown Pride. We've done a community survey and we've asked people, have you experienced relational violence? Have you gone for assistance? What would help you? We're going to take that and we're going to create a needs assessment and we're going to do a strategic plan and really lean into that lived experience. Because I think the future of what we do is rooted in the experiences of our community. And we can't have this, idea that everything that I think or our community partners think is going to work. Unfortunately, it doesn't work like that. So I think when we have that work hand in hand, it's really important. I also think we need to make sure that people who are of the community are part of these agencies. They have to have a voice in the work that is happening. That means we need to recruit people to be on staff, to be on our boards, to be volunteers, to help with the decision making. So
I'll echo that. I think oftentimes when we're first building a program, we'll go to the community and ask for their input. And then somewhere along the lines, their voices aren't always represented. So I think certainly starting by asking them, but I think continual and sustained engagement and involvement. I mean, I think one of the things that, you and I talk about a lot, Terri, is compensation, right? So oftentimes we go into these communities and we ask them, tell our stories, tell us your stories. And we go and we take up all the goodness, but without the compensation or without the opportunity or extending the opportunity to continue to be involved. And so I think that's also really, really important. I love what you said about staff and recruiting and retaining, and also really understanding how, like, the role that how it might impact these workers, right? So Terri and I did a study looking at the impact that the pandemic, it wasn't a central question to our study, but it came up about the impact that this has had, the pandemic, and doing this work on the front lines have had our Black advocates, and kind of understanding that in real time, they're navigating the pandemic, watching systemic racism play out on a larger scale, right? And also doing this work. And so really being thoughtful to these experiences and providing support when needed.
Yeah, I'll just add, there's something that I always think in my mind that a researcher that I formerly worked with said, and it's like, don't treat communities like you're going through a McDonald's drive-through line. And communities have been burned many times. And so researchers are met understandably with a lot of distrust. And so if you're going to work in these communities, you have to be in it for the long haul, and you have to invest in ways that the community finds would be helpful. And so having those conversations, also being transparent, like our bread and butter and our careers are built on publications, and it's much more honest to be transparent about that and to share that piece with folks, and then to see like what's going to build your desires, what's going to build your goals, and to have honest conversations rather than trying to like skirt the topic. I think
honest conversations and that investment are so on point. Running an organization and the ops lens, it's really hard often to do the things that people tell us, right? And so I think from an investment point of view, we need to build in and hardwire. It will cost more money to listen to lived experience in an authentic way, which we are committed to doing. We need to plan for it to take longer and it to cost more. The voices of the women and children who informed our service had amazing suggestions, but they were far harder to do. You know, and I think that's the thing, like it takes longer, and we need to be real, because if we're going to listen to lived experience, it's not, oh, okay, this was the plan. Oh, they don't want that plan. Like, we've got to be real. And I think being transparent about when we're asking for feedback, which part of it there's scope to flex with. Because if we're going to do consultation, do consultation. If we're going to inform you, let's just say that we're going to inform you. We can't always co-design, but where we are co-designing, make sure we've got a budget planned and time planned so that our stakeholders are across the fact that we're going to do this really slowly and authentically, and we're going to listen and we're going to check that we got it right. Because when it's built, we want to be able to say, that, hey, you know, for example, Frida, one of the elders who said to me in the early stages of the design that she wanted to be able to see the stars. So it was like she was sleeping out in Carlup. And, you know, when she came back and visited and was like, you've built it with no roof. Like, yeah, we did. And I think, you know, the things that are so important to us around listening to the failures of the system before us and the experiences of women today, the things that people suggest might not be the easy way, right? So we need to like build it into the system and be bold around, yeah, we can do this, but it's not going to look the same. And I think like being really courageous around how we listen to lived experience. Otherwise, it's just not going to land. It becomes tokenistic.
Yeah, I really like that approach. So most of my work has been in the Southwest. I'm actually did most of my career in Phoenix, Arizona, and I worked with Mesa Municipal Courts. And I also do a lot of work on structural intersectionality. So how do we plan and design systems? And they started at Mesa Municipal Court, a community court, so a holistic problem-solving court for misdemeanor defendants. And they structured it off of what you see in New York City, right? So let's do housing, drug and alcohol, let's do employment, right? But so I said, well, you're collecting any data? And he said, no. I said, let me. And so we came in and I thought I would do, so we got a study on victimization needs among community court defendants. And what we found was that the domestic violence victimization rates were incredibly high, and there was no provision for domestic violence services. And I'm so impressed that you have it, because their ideal defendant that they had planned for was a man. And so it wasn't an issue. And so we did a study, and I actually got to the privilege of talking to over 100 defendants and then doing some interviews outside the court in a park one morning. And the women told me they stayed in the violent relationships because being an unhoused woman was more dangerous. They knew him, and she was like, he has a problem with knives, but I know when he's going to have a problem, and so I can manage that. But another one of the women said she was sleeping alone and woke up to someone unzipping my pants. She said, of the two situations, I will pick the abusive partner. Well, Mesa Municipal now has a whole domestic violence services thing for this issue. So these women sharing their stories, and the men, I also spoke with them and they said the same thing. But so it's much harder in the short term and there are much more costs, but 5 years out, Mesa's performance is so much better. They are administering justice so much more efficiently and effectively, and they're meeting their goals. And so I guess it's a matter of that short, long-term trade-off, right? In the long term, it's a short-term investment with very long-term payoffs.
So I'm conscious of time. It's already almost 7:15, and I want to leave time for our audience to get to ask questions. So do we have any, should I run around with the microphone? Are you? Okay. Do we have any initial questions?
Any questions?
Thank you for the presentation. It was really terrific. I applaud the bold nature of doing things differently and not having to just do it the same way it has always been done, especially if you have clear evidence that perhaps something doesn't work as well that way. So I applaud that, that it is courageous. You are correct. I'm wondering from the financial model side, right? We understand philanthropy has been generous in some spaces at least, but I'm curious, what's the average stay of one of your clients? In the space is gorgeous, and it's really a wraparound, very, very holistic from the human element. And I'm just kind of curious on length of stay, because that would then drive also the amount of philanthropy that you are requiring in order to be able to support the clients and their children.
Thank you. It's a very good question. The service is modeled on healing and recovery being the focus. And so what that means from a bed stay point of view and a system pipeline point of view is that the Carlup service allows capacity in our refuges. So refuges are crisis spaces where someone can come in tonight, low barrier service as they are, and go into a refuge. Our Call Up service is the step on from that, which is a focus on healing and recovery when there's not that crisis. And so what that from a system level does is enables flow and it allows refuge beds. And the reason that's important is from a funding point of view, in allowing capacity at the crisis end, we're able to do that more longer term work on healing and recovery. In terms of the philanthropic funding, I guess one of the things that we have been really bold in and really clear with people is that length of stay and bed units isn't the measure. And we've been really upfront in designing and working with researchers throughout. So we've been really clear on the expectations of this is what good looks like. And we're not going to exit someone into homelessness. So while we modelled the service on 3 months, being the length of stay, the reality is it's been far longer than that. And the reason for that is because we're in a housing crisis, and having an affordable rental where someone can, have their kids in school that are thriving and have their pet with them and the things that really matter to them to really heal and recover are not possible. So to meet the 3 months, we would need to really go backwards. And I think where we've been really especially bold and we're exceptionally grateful for the philanthropist creativity to understand that and work with us. And we've been able to show that the outcomes of doing this are far greater and have far longer lasting impact, because sticking to the 3 months might have looked good. We might have had more throughput and more utilization of the service. But what we know is that for these people, recovery isn't short, it's lifelong. So we're probably looking at, 7 months at the moment being a length of stay. Some people have gone, we've had one person who's gone into rehab, which is a good story, as in they've acknowledged that they want to work on their alcohol and drug use. And the rest of the women and children have gone into stable and supported housing, where we continue to support them ongoing. They're just not residential. So we also, like that, the 600 people we're able to support are not all upstairs in the units. There's 13 units. And then people are in the community, so we support them regardless, wrap around.
I have a question. One of the things when we teach our IPE classes, we tell our students we're giving you the tools to work in a healthcare system. We have no idea what it's going to be moving forward, right? We've said we hope the system evolves, right? And when you're making such massive kind of paradigm shift within the care plan, right? The care team, that really challenges people's sense of role, sense of themselves. And what kind of development do you do, any of you in any of your roles, about helping people with that transition to a new role in the system, to a new sense of my identity as a health professional, or as a carer, as a friend, as a family member, all those types of things like that. Because if what's happening now is not working well for people, how are we going to get people to start thinking differently about who they are, what their role is, what their duty is, those types of things like that? So I have that question for you.
So I'll kind of touch on it. I think one of the things that I have seen over the 20 odd years that I've worked in nonprofit, and so some of this will be health and some of this will be the broader social determinants of health, is that sometimes people have a really hard time being super flexible and changing their models to fit the needs of the community or the needs or the strategies that are going to be following from there. And so explicitly when I'm talking to nonprofits and I'm talking to them about having safe, inclusive spaces for the LGBTQIA+, I'm like, that means that your policies need to look different. That means that maybe some of your roles need to look different. That may mean that training needs to happen. That may mean that you need to change some of the strategies or the way you do your work on a day-to-day basis. And that is really difficult to get people on board with. But I think for myself, when I'm working with several nonprofits, when they start seeing this like common vision and the understanding of the why, the senior leaderships really starts to understand that, and some of that starts trickling down. But I think that is so difficult to get everyone on the same page, and people get very stuck in the same old, this is the way we've always done it, we don't have funding for that, that's a new strategy. But I mean, I like to take risks, and I like to know that the work that we're doing is pushing us further and making sure that it's accessible for everyone. So that's what I've seen in nonprofit, and that's even in St. Louis.
One of the things that I really appreciated about your talk that I haven't said yet was when you talked about being brave, talked about let's try it. And an implicit in let's try it is it's okay to fail. I think when you deal with these big issues like medical care and domestic violence and the unhoused, we are so afraid to do it wrong, we would rather not act, right? Do no harm sometimes might mean staying silent because you don't want to say the wrong thing, you don't want to make it worse. And so maybe opening, like, tell me how you open up that space, right? I want to hear about that, because I think opening up the space where we could all fail or say, you know what, I don't know what to say right now, but I want to say something. So
yeah, I think the way we did this was making sure that we failed fast, but we knew what we could fail in and what the things that were locked in that we didn't touch and we didn't ever accept failure in. And that was really safety and culture. You know, we need strong teams to deliver on this work, and anything that impacted culture negatively, we didn't want to fail on. And safety was the pillar of everything we were doing in terms of non-maleficence, of doing no harm. Things that you can fail on are things like, what if we did our huddle and everyone came together in the morning and we talked about risk assessments? Like, what can go wrong if we try that? What could go wrong if instead of having to call the receptionist, you just called the doctor directly? It's like what can go wrong in that? Let's just try that. Let's try it now. Like, let's just reroute the phone. I'm calling the director of IT myself. Like, I literally did that. What can go wrong if we all walk around and do things differently and understand the flow? I think in terms of multi-D teams, we talk about role clarity. That's essential. Another thing that's essential is understanding where they're coming from. So the nurse isn't lacking a trauma-informed approach. She's just worried about your neurological decline. And what she's looking at is the fact that she's wanting to really check everything out because she's concerned about a physical health element, where the lawyer isn't talking to you. It's not because they don't respect you. It's because they're worried about client privilege, and there's different relationships around child protection. So I think in terms of that multi-D team, it's an understanding not only for what I do, but for what you do and what lens you're looking at the person with. Because I think so often there's this like, oh, don't go and see the nurse because they're like medical model and they're evil. It's like, they're not. Like, it's just different because we're looking at things with different lenses. And I think that's the stuff that we've failed fast in bringing people in, and like the nurse talking to our teams and saying, hey, do you know that while the council is booked out and they're full, I can actually do some of that? Maybe not as well as you, but let's try it. And it's worked really well.
The research does suggest nurses are very good counselors and therapists. No, folks know that. Also, all models of therapy work. I don't know if that's going to be news, but like there's so many, I'm just sitting here thinking about meeting the immediate need and not getting worried about stretching roles in some way, and also violating norms, calling the doctor directly. You just broke 4 rules that I was told about having to go through all these different places, right? Because there's also hierarchy, right, in medical models and in different, sometimes integrative teams I've been on. And so how do we, those are rules we made up that could be different, right? And no one's going to be harmed by breaking those kinds of professional rules necessarily. You might have to overcome culture or norms, but yeah, but like, why not? Worst case scenario, doctor's mad at me. I don't know.
Just quickly, we asked the doctor and they were like, yeah, that's way easier. It was everybody else who had a problem with it. If you just ask the person, hey, could we try this? It made their life easier. They just wanted facts.
And going back to the initial question, I think people will hold on to a broken system out of fear that they will do the new one wrong. I would rather do it and complain about it and know it's not right, but know I'm doing my job right than try something new where I can fail.
I was going to say also, especially with nonprofits, they are so tied to the outcomes and the funders are so stringent about those outcomes that they will not give themselves the flexibility to make changes. And I think more philanthropists are understanding that like we need general operating support. We don't need you to micromanage the outcomes because we're going to tell you the outcomes. We want to be flexible enough to meet people where they're at. And if we had more funding like that, I think we would have better outcomes.
We're getting to the end of time here. Last comments, especially from our esteemed guest, Elsie.
My final comment I think that everyone's got the answers. You guys, we've all got the same answers, even across, however many hours away I flew. It's being bold. It's backing ourselves and listening to the experts are the women and children who tell their stories. Let's create space for that to be the truth, and let's get it done. Let's just get on with it. There's so much work to do, and I think we're a collective and we've got this, and let's create space to make sure that we don't ask people again. We've heard the answers. We keep asking them as well, but let's just start doing what we've heard. And there's so much work to do, but together we've got this. I think regardless of our profession or the role we play as a society, this is a problem that we need to be addressing and we need to end it. I think let's end family domestic violence.
That's wonderful. Thank you so much, Elsie. Any other last comment? Sure.
Is it on? Yeah. This is the hardest part about the talk is turning on the microphone. Yeah, I think less talk, more doing. I'll just echo that. I'll keep it short. Yeah, I think we know what to do, what we don't know, we can talk a little bit about and learn a little bit more, but let's get to action.
As I reflect on my role as a researcher with a clinical background, I think a lot of the work that I've done and together with Terri, we've kind of thought about from every step of the research process, from conceptualization to developing our consent documents to developing our, our metrics and our interview guide and results and interpretation and what next, involving the community and involving those with lived experience, because that is what's going to give us legs, and that is what that is going to be what lends credibility to the work that we're doing and sustainability.
Yeah, I mean, I think I just keep thinking of innovation and flexibility. Now we got to figure out the money part, but innovation and flexibility.
I guess for me, and I don't know about all of you, but there's a necessary part too now where we all come see you and in Perth and get to come see this fabulous place.
Perfect. Thank you, everyone.
This was amazing. Thank you all very much. It was not bad for a first try. I think we did well. We do have an appreciation gift for all of you, so thank you very much. Would people please complete the survey? If you complete the survey and you put your information in, we will send you a certificate of completion, which can be used towards our new micro-credential and interprofessional collaboration, which we're excited about. Just give us your feedback about how you think things went. But once again, another round of applause for our panel. They're pretty amazing. Thank you.